Next on stage, Dr. Guy Northover, who is also from NHS England's Getting It Right First Time programme. He's the clinical lead for children and young people's mental health. And I was going through his biography to find a few things to introduce him. I thought he's a truly Renaissance man. There's nothing that he cannot do. I mean, clinical expertise in urgent care, crisis work, early intervention, health informatics, big data, population health, digital systems, digital interventions, clinical directorship in quality assurance, safety, effectiveness, workforce issues when it comes to recruitment, retention, and in psychiatry. So Dr. Northover, over to you to tell us all. Thank you. Please, a round of applause for our speaker.
Right, well, good morning, everyone. The one thing I would say as well is you've probably gathered I absolutely love data. My perfect Friday night is going down the pub with my mates and talking about data. And I do still have some mates, which is probably a good thing. Talking about data, I have got loads of slides with data on it. Okay, so please, in your own minds, if you want to convert it to lots, a few, or none, that's absolutely fine, and these slides will be available afterwards. I'm just going to talk about children and young people mental health. Just one reflection on what Shri was talking about. In child and adolescent services, we really don't even have rehab services. And in fact, if a young person needs rehab services, they end up in what are called low secure units. We criminalise rehab for young people at a very, very early age. And I think this is an area which we really need to be focusing on. If you want the local authority to support a young person who's had a significant mental illness in the community, that's a real challenge. I've got a young person at the moment who has been detained under the Mental Health Act who needs to go to our day hospital. The local authority are not funding a taxi and the parents can't get them there, so they're not getting the treatment that they need. But I won't go down that line because I'm not here to talk about that. Right, first of all, what's the problem? So we all know that mental health difficulties in children and young people are going up. You know, we actually know when we look at this data that at the moment, among 6 to 16-year-olds in England, 1 in 6 have got a probable mental health condition, which was up from 1 in 9 in 2017. You know, and if we actually look at adolescent girls, that's 1 in 4 have got a probable mental health condition. You know, that is a scary situation for us to be in as a country. The rise in prevalence since 2017 is the equivalent of 500,000 more young people requiring mental health services. And just hold that figure in mind for the next slide. And eating disorders, it's possibly even worse. So in 2022, 62.2% of young people who were reported on in probably the largest prevalent study of mental health difficulties screened positive for a probable eating disorder. Yeah, that's a lot. So what does that look like? This is one of my first charts. Oh, actually, it might be big enough that you can read some of the numbers. Normally, it's impossible to read what I'm putting up. So this is just showing the number of children and young people who are accessing mental health services. And as you can see, from 2021, which is where that previous data was, it was 572. The prevalence data suggested we needed another 500,000 just to meet the increase in the prevalence. We're up to 697,000 young people accessing mental health services. So it's gone up, but it's not gone up nearly as far as the prevalence rates would suggest. If we consider actually that there are 14 million children in the UK aged under 18, if we think at the moment that there are 700,000 young people who are accessing care, that's 5% of our youth population receiving mental health services. So what does it look like in terms of waiting? Well, here we go. You can see on the charts here. Let me get my little pointer out. So we can see that we've had a consistent increase in the number of young people who are waiting for mental health services. And again, I think this number here is quite interesting, so again, it will be reflected on the next slide. We can see that there's been quite a significant increase from 2021 to 21-22, probably close to 700 to 800 more young people waiting either for a first appointment or a second appointment. We count second appointments in child and adolescent services because your first appointment is usually a phone call saying, hey, how are you doing? What difficulties have you got? What service do you need? So you usually don't get your assessment until the second appointment, and you usually don't start getting any treatment in your third, fourth, or fifth appointment. And then we can see in terms of the referrals have gone up. The accepted referrals has gone up by 900, and the number of patients on the caseload have gone up, again, where's my pointer? Have probably gone up by around about 900. So that doesn't really look very good, because we can see that our waiting list has gone up by around about 900, our referrals accepted have gone up by around about 900, and the number of patients on the caseload have gone up by around about 900. So all of that increase has effectively gone to young people waiting for services rather than receiving them. Which, when we actually look at the number of contacts that are being made, we can see over the same period that there's been a significant increase in the number of contacts for young people with mental health problems. That's gone up by around about 6,000. We can see that there's been a significant increase in the workforce, which again has gone up significantly. The productivity hasn't gone up though. That stayed exactly the same, so the number of contacts per team has effectively stayed the same. But how is it that we've had this increase in contacts, but we can see that the increase in demand has almost all gone onto waiting lists? So something is going wrong in terms of the way that we're doing our services. Just moving on a little bit to think about where we are in terms of whether we're doing a good job or not. This is data from the NHS providers, and this was data from around about 2 years ago. And it was effectively asking the providers, which of their services are they most worried about? And we can see that 81% of returns said that their community CAM services were not meeting demand. Whereas in actual fact, only 29 of those suggested that inpatient CAMS wasn't meeting its demand. And we mostly hear about inpatient services when we're working within mental health services. And I think that in itself is quite interesting because inpatient care in CAMS takes half the CAMS budget. Okay, we heard Shri talking about the rehabilitation costs of 1 billion for their inpatient services. Within CAMS, the cost of the inpatient services is around about £500 million, but the total funding to CAMS services is somewhere between 1 billion to 1.2 billion. So almost half of the CAMS funding goes into this area. And then we look at this slide, and potentially that's not the area it should be going into. I've got lots of other data as well around this. So there's a real question if inpatient care is working at the moment. So the average length of stay has gone up over the last 5 years. Each year it goes up. The number of inpatient beds has stayed steady despite an increase in funding and despite an increase in new units opening. Each time a new unit opens, it feels like one closes elsewhere because of quality concerns. The chances of you being restrained as a child is 4.7 times more likely than an adult in the same organisation. So again, what is it that's happening in there, and should we be focusing all of our attentions on the inpatient care? Oh, look, another slide saying that things aren't really working. I'm not just going to talk about things not working, I promise. So crisis avoidance. This is data from Will, who's probably sitting next to Susanna, who collects all the data within GIRFT, has recently refreshed our GIRFT data. And this comes from that data, and it looks at the number of contacts a young person has before they're seen within a crisis service. And what we can see here is that 60% of the young people who end up in a crisis service have not been seen 3 times in the previous month. So that suggests they're not getting the right crisis avoidance work and going straight into a crisis. And if we look at this, around about 40% haven't been seen in the last year. So where are these people in a crisis coming from? We've really got to be thinking about this as a whole pathway. And this is what I'm trying to think about here. So I've had a little bit about the inpatient care, a little bit about the crisis care, and I'm going to move into a few conditions now. Right, autism. We can't avoid autism either, because autism is common, and we know that waits within mental health services are probably the longest for autism. And what this slide is basically showing, and I'm going to go over it a bit quickly because I will definitely run out of time otherwise, is what it is basically saying is that if we wanted to assess everybody who should require an assessment for autism, we'd need to be assessing about 2.6% of the population. So that's quite a lot. I was going to ask everybody to guess how long an autism assessment takes on average, but I think there's probably too many people in the room. But if anybody thinks that 13 hours is the right answer, I'll be surprised, but that is the answer. NHS England has identified an autism assessment takes 13 hours of clinicians' time to undertake. I'm not convinced of that, by the way, but that's what they're saying. But you can see from the autism assessment pathway that it is a complex pathway that requires a lot of steps and a lot of interventions at different stages. Not only that, we know that we have a significant underdiagnosis of autism over all ages. So we're looking at probably maybe 60% of autistic people are presently undiagnosed. So what does that look when we come to waiting times? So the top line here is the number of new suspected autism referrals which are made every month. The bottom line is those that are closed. So the bottom line are those people who have had an autism assessment and been discharged from the autism assessment process. Now, you don't need to be too good at maths to realise that if you've got 9,131 people being referred every month and you're only discharging 5,242, that waiting lists are going to be going up, not down. Yeah, so even based on what I've said, the fact we're not assessing enough people, there's undiagnosed people in the community, we are also missing our target of how many we should be assessing by 4,000 people a month. NHS England has done a bit of statistical modelling around this, and what they reckon is that it will cost £135 million just to address the waiting list. And if we see £135 million coming towards autism assessments from the NHS, I'll be very surprised. So, what can we do about this? So first of all, do we need to change the way services are funded? So we're looking very much within CAMS around currency models. So currency models is trying to move away from this idea of a block contract. So it's trying to get services to understand what's coming through the front door, what are you doing, and how much is that costing. That's going to be based around a Thrive model, which I'll come to in a little bit. And the other part is the pathways development. So we have a real problem with pathways in mental health services. When I was talking about the productivity side of things earlier, I suspect, I haven't got the evidence for this, but I suspect this is being driven by the fact that we've pathwayed everything. So if you've got psychosis, ADHD, anxiety, and autism, you're going to be on 4 pathways. Yeah, you're going to get 4 assessments. You're going to get 4 lots of treatment plans. Whereas possibly having 1 or 2 clinicians who are skilled enough to manage all of those conditions would be more effective and efficient. I work in early intervention in psychosis. I find it difficult to break the system to do autism assessments. Because if I do an autism assessment myself, the autism pathway tells me that actually I've probably either done the wrong thing, haven't filled out the right forms, haven't referred at the right time, and haven't asked the right questions. I think, having been a consultant child and adolescent psychiatrist for 13 years, having assessed autism throughout all of that time, I am still capable of doing that. I'm not bitter about that either. So the other part which I'll talk about is the GIRFT community project. So I've mentioned the inpatient care, but we need to shift our focus from inpatient to the community. We need to think about the whole pathway. So I'll describe a little bit about what we're doing that. And then there's a little bit about autism assessments. I'm going to move on to the autism assessments first, actually. Oh, I've put digital at the bottom as well, because I like digital. And there's got to be some digital solution to everything. Well, you never know. So we've got ourselves in a situation of stuck in a process of reassessments. Do all autism assessments need a full comprehensive process that takes 13 hours? And again, I would say no, but I say how can we actually define which ones do need a long, full comprehensive process and which ones don't? Going to the digital question, within Oxford, they're trying to develop a system which is using artificial intelligence to identify which people are more likely to require a full autism assessment and which ones aren't. It's right at the very beginning of the process, so I suspect it will probably be 5 to 8 years before they've actually got anything which can be used. The other part of it, who else in the system can diagnose? Does it always have to need to be a specialist CAMS clinician who's making a diagnosis of autism? When I started, we worked very, very closely with educational psychology teams, and we would be able to split an autism assessment between the 2 teams, base it within the school, and probably give a more comprehensive assessment. Right, the assessment process is too long. Honestly, 13 hours is too long. It doesn't matter if NHS England are saying it takes 13 hours. It should not take 13 hours to assess anything. So what can we actually do to decrease this clinical time? What can be done in terms of the data collection, the information collection before the clinician sees the patient? And also, other assessments often cover most of the autism assessment. Again, in Berkshire, we do ADHD assessments here, autism assessments here, and we ask 70% of the same questions in both assessments. I'm clinical director there, and it really frustrates me that I haven't been able to make any changes there. And the final part is, why do we diagnose? Does everybody who has got autism need an autism diagnosis? One of the reasons we diagnose is that in the education system, if you don't have a diagnosis, you don't get the same level of support. So is that an area that also needs to shift a little bit? Within the rest of mental health, particularly child and adolescent mental health, we're moving away from diagnoses and into complex formulations. But when it comes to neurodiversity, we're moving further and further away from formulations and more towards diagnosis. So what is it that's causing this difference between neurodiversity and the rest of mental health? Right, I'm just going to talk about GIRFT a little bit. The first bit is just me showing off, because I like to remind myself that having worked with NHS England and GIRFT, I've actually achieved something. Well, again, I have to say Susanna probably achieved most of this, but I've got quite good at taking credit from other people. So we've written a national report which is looking at the inpatient care. It's got 21 recommendations. We've inputted and supported the development of an eating disorder model, which suggests that actually eating disorder patients are not best managed within psychiatric inpatient units. They're best managed as a physical health crisis that requires the refeeding and the support in the community. We've got new service specification for children and young people in patient units to make them more family focused. So again, one of the ideas is that we need less units, but they need to be more responsive, and they need to be more able to look at the whole system. So for example, within the new service specification, being able to admit the family along with the young person is something that is going to be recommended. We've developed quite significant outcomes in the currency work I was talking about. We've got a number of best practice forums which are sharing best practice across inpatient units. The specialist commissioning, so inpatient units are commissioned through specialist commissioning. They're not commissioned through the usual routes within CAMS. But we now have a robust data pack that goes to the specialist commissioning on a monthly basis, so they can actually see and benchmark themselves on what's happening. There's been a massive expansion of crisis and home treatment teams. I've developed a psychosis pathway, which I was going to show off, but I'm pretty damn sure I'm going to run out of time, so you'll just have to take my word for that one. And we've redeveloped the gateway metrics, which will have spent a huge amount of time, so we can actually look and benchmark where inpatient services are now. I don't need to show this slide, because coming after Shree's been able to talk about GIRFT. The one thing I do want to mention, GIRFT is about quality improvement. It is not about regulation or assurance. So you're not there to try and say you're doing something really bad, stop doing that. It's where's the best practice, how can we move the curve so everybody is doing better. Shree's already mentioned that, so I'll jump across that. This is what we're doing next within GIRFT. So we're moving away from the inpatient service, and we're moving to focus on the community and waitlist initiatives. And this is our vision, which is through the use of data and clinical leadership, we want to make sure that all children, young people, mental health community services are providing the high quality, efficient care that is required, and actually reducing waiting lists. Within this, for me, is also a drive for us to stop focusing on resource, because we know workforce is an issue, we know resource is an issue, but if we keep focusing on that, we keep on coming back to the same answers over and over again. So how can we start focusing on the problem that we have based on the resource that we've got? So the second part about the community work that we're going to do is we're going to look at this around the whole system. We want to look at what's happening within primary care, what's happening in secondary care, what's happening within the voluntary services, what's happening within the schools. And we're going to do this by basing our work on the Thrive lens, and I'll come to that in just a second. We're going to do the same work as Shree described, so we're going to be developing a data pack, which is looking at the data across more of using more of this Thrive model. We're going to initially pilot this with 2 organisations, because I promise you, we will not get as much data as we need. We need to understand from these systems what the data really means. Do we need to be collecting data for waiting lists around first contact, second contact, third contact, fourth contact, fifth contact? I can't tell you at the moment, because every trust does it differently. So we need to really explore and understand what we're looking at. That was a bit about the waiting times. And then we're embedding the change process and support right from the beginning, because this change is going to be difficult, because we are going to be asking a lot of community services to completely change their idea of what child and adolescent mental health services are. Where should people be seen at what point? So we're working closely with NHS England and the policy teams for us to think about how the regional teams can support the GIRFT work, and the GIRFT work can support the regional teams. The final part of it, what we're doing is I'm bailing out and escaping from GIRFT. Basically because my expertise is much more around the crisis and the inpatient care, and this work has to be led by somebody who can absolutely stand up and demonstrate themselves to be an expert in the field. It's also 8 years in NHS England is a long time. Yeah. And then this is just an idea in terms of what we will be collecting in terms of data. It's all fairly basic data, but getting it is quite a challenge. So when I talk about the Thrive model, this is basically what I mean. So rather than the traditional way of describing CAMS, which is your tier 1, your tier 2, and your tier 3, so tier 1 being primary care, tier 2 being secondary care, tier 2 being primary care, tier 3 being secondary care, tier 4 being specialist care, and tier 1 being prevention, it's trying to shift the conversation away from tiers and organisations to what the young person needs at each point. But this allows us to think a little bit more about the preventative work, and it allows us to think actually that very specialist care provided by specialist CAMS may not always be the right care. But we really need to understand the data and understand what's being driven at each point to get this to work. We also need multiple organisations to work together. So the Thrive model doesn't work unless the local authority, the voluntary sector, and the NHS sectors are working together. And that in itself is a huge challenge. Part of my belief in data is that if we get the data, we can show, as Sri has done around the independent sector with rehabilitation, if we can show that data across the whole system, show it to the leaders there, then we will start being able to bring a little bit of a shift in how we see and how we support people with mental health problems. How much time have I got left? I might actually, I'm just surprised, I might get onto my pathway. Sorry? I've got time for my pathway. Okay. So the final part, it's how do we use data to develop pathways? So pathways need to be cross-organisational and cross-service. Pathways are often not that at all. So within GIRFT, we've got a real opportunity to, again, think about specific pathways and think about how they work across different organisations. The first pathway that we focused on was psychosis. The reason why we focused on psychosis is you've got great early intervention in psychosis teams. They start at the age of 14, and the evidence behind those teams is not great for child and adolescent mental health services. It's also, when you've got an early intervention in psychosis team, you've already started to create a siloed position of care. So how do we create a pathway that works across all the services that are providing support to children and young people who have got psychosis? You really need to speak to people about pathways because everybody has got their view about what happens, what works and what doesn't work, and you need the evidence and the data to back you up. So part of the data that I was able to have around this is your average early intervention in psychosis team has a caseload of around about 260 young people. Out of those 260, on average, 4 of them are there under the age of 18. Yeah? If you look at the prevalence and the incidence data of psychosis, then you should be having considerably more young people within those services. So something has gone wrong with those early intervention teams that has started focusing on the adult population at the expense of the children and young people. We know 14% of people within early intervention psychosis service end up in rehabilitation. I'd be really interested to find out how many of those were referred before the age of 18. So this is what my pathway looks like. Now, I'm pretty sure this you can't read. So if we do break it down slightly, so it's about how do we identify each stage, but also, more importantly, how do we identify the data collection points and how do we let clinicians be confident that the points in the pathway are evidence-based. So the blue bits are evidence-based. We've got a set of data points within that as well. And we're looking at the initial triage, what happens at the first point of referral, how do you manage it under a psychosis pathway, not under an early intervention psychosis team. That's part of the pathway, but that's not what we're looking at. How do we support young people in a crisis with psychosis? That is a real challenge in CAMS. We end up putting kids with psychosis or having a crisis in a team that doesn't know how to support them. So if we need to bring those into a fully comprehensive pathway as well. Then the final bit in a pathway is we need to focus at the at-risk mental states. So at-risk mental states are young people who are presenting in such a way that they're likely to develop a psychosis in the near future. So that might be somebody who's got some strongly held beliefs which may be delusional but may not actually be at a point where they'd meet all the criteria for a psychosis. What support can we then offer them which may or may not stop them developing a full psychosis? So that was my pathway. I've just got the evidence base behind that. And I think that is probably me done. Thank you.